Welcome to the webinar, Sources for Sick Childcare, a global analysis of DHS data from 24 USAID maternal and child survival priority countries. Today's webinar is brought to you by Sustaining Health Outcomes through the Private Sector Plus project, also known as SHOPS Plus. I'm Tess Shiras, a research specialist with the SHOPS Plus project. SHOPS Plus is USAID's flagship initiative in private sector health. Led by ACT Associates, the project aims to increase use of priority health services through the strategic expansion of private sector approaches in the health system. It focuses on maternal and child health, family planning, and HIV. Today's webinar, of course, will focus on child health and sources of care seeking. Before we begin, let me direct your attention to the chat box on the right of your screen. Use this box to ask a question or make a comment. Please feel free to include your name, organization, or location. Send your comments and questions at any time, and we will get to as many of them as we can following the presentation. We are also recording today's webinar. We will make the recording and slides available on our website, as well as sending them out to all registrants. We have people from nearly 30 different countries around the world registered, making today's webinar truly a global event. Let me extend a warm welcome to all of you, and thank you for joining. Today's webinar is the first in a series on sources for sick childcare. Over the next 3 Tuesdays in July, we will be holding regional webinars to highlight country-specific findings. We encourage you to join the upcoming webinars for the regions relevant to your work. You can find the registration links in the webinar chat box right now. We will also share these registration links following today's event. To kick off this morning's presentation, I would like to introduce Malia Boggs, who is a Senior Child Health Technical Advisor at the Office of Maternal, Child Health, and Nutrition with the USAID Bureau for Global Health. Malia has over 20 years of experience in international public health, 13 of which have been at USAID. She has designed, implemented, managed, and evaluated public health programs in Africa, Asia, and the Pacific. Currently, her role includes providing technical oversight to child health activities under the SHOPS Plus project, such as this one. Malia has been a fundamental part of our team as we worked on this secondary analysis of sick child care sources. Over to you, Malia.
Thanks so much, Tess. Good morning, afternoon, and evening to those of you who are joining us in different time zones. My name is Malia Boggs, and even though it's 3 a.m. here, I'm thrilled to welcome all of you to this global webinar on sources of sick child care across 24 of USAID's priority maternal and child survival countries. As Tess said, this is our inaugural event, kicking off the first in a series of 4 exciting webinars on the topic. As you may know, for decades, USAID has supported low and middle income countries to accelerate reductions in under 5 mortality, especially from preventable causes. These efforts, along with the work of other partners, have resulted in a tremendous decline in the annual number of under 5 deaths, from 12.6 million in 1990 to about 5.6 million today, or a 56% drop. This means that around the globe, 20,000 more children will live each day of this year than in 1990. The Economist has called this stunning reduction in mortality the best story in development. Progress, though, has been uneven, reflecting inequities in access to or use of health services and highlighting the gap between rich and poor. As a result, there remains a significant unfinished agenda to improve child health. USAID remains committed to working with governments and partners to reach the ambitious targets of reducing under 5 mortality to 25 or fewer deaths per 1,000 live births and 12 or fewer newborn deaths per 1,000 live births in every country by 2030. However, country-specific analyses of annual rates of under 5 mortality reduction reveal a need to accelerate progress in order to meet the 2030 targets in many of the countries USAID supports. Understanding if and where caregivers seek advice or treatment when their children are sick is critical to addressing the barriers to care, and to focusing interventions to improve quality of care to reduce child morbidity and mortality. Recognizing this need, USAID Washington provided funding to the SHOPS Plus project, which, as Tess mentioned, is USAID's flagship private sector health project, to conduct a secondary analysis of the most recent demographic and health surveys in 24 out of our 25 priority countries. This analysis looks at 3 common and treatable illnesses that are leading causes of childhood death: fever, diarrhea, and symptoms of acute respiratory infection. The SHOPS Plus research team examined care-seeking patterns for these 3 illnesses at a country, regional, and global level. This analysis has resulted in a multitude of products, including a global brief, as well as individual country-specific briefs and slide decks. Links to all of the products will be available at the end of the webinar. We are excited that this research is highlighting the important role that both the public and private sectors play in child health. The team has been intentional in how results are packaged and framed, relying heavily on data visualizations to increase the usability of this evidence. The results can be used at a global advocacy level to disseminate key takeaway messages. At the same time, we hope this information is actionable at the country level to inform programmatic decisions that will ultimately improve child survival. USAID continues to support the vision of preventing child death, which entails working together with key stakeholders in both the public and private sectors to mobilize the collective resources and political will to focus efforts on the most effective interventions to prevent those deaths. Today, Sarah Bradley, who is the SHOPS Plus Global Research Director and the principal investigator on this study, will present the findings of the global analysis. Sarah has 15 years of experience in international public health research, most recently as a senior research associate for DHS. Sarah will compare and contrast patterns in childhood illness burden, levels of care seeking, and sources of care seeking across regions and specific countries. I encourage everyone to ask questions through the chat feature and to tune back in over the next few weeks for the regional webinars that will feature USAID missions. With that, I'll hand the mic over to you, Sarah.
Great. Thanks very much for that intro, Malia. You sound very sprightly for it being 3 a.m. Thanks also to Tess, who, along with Lauren Rosapep, co-authored the analysis. The 3 of us are the research team. I'm going to try to be pretty quick with my presentation, probably about 25 minutes, so we have lots of time left for your questions, and you can submit those at any time, as Tess mentioned. At the end of the hour, we're also going to show you how to access and use the resources that Malia mentioned to dig deeper into the data. Including, we're going to preview for you our brand new remodeled private sector counts tool, which is an interactive data visualization web tool allowing you to analyze and visualize the data for yourself. We'll give a tour of this at the very end of the presentation. This slide shows the scope of our analysis. As Malia mentioned, USAID selected these 25 priority countries in part because they have some of the highest levels of maternal and child mortality in the world. We're lucky to have recent nationally representative demographic and health survey, or DHS data, for 24 of these countries, shaded here in dark blue. We were especially lucky to be able to incorporate brand newly available data from Ethiopia, Uganda, and India. We used 4 research questions to frame our analysis, and I'm using them today to frame the order of this presentation. First, we looked at what is the burden of disease in these countries. How common is it for children to experience fever, acute respiratory infection or ARI symptoms, and/or diarrheal disease? Second, when their children fall ill, what percentage of parents or caregivers seek treatment for their sick children? Third, we'll look at where caregivers take their sick kids. Do they go to the public sector, the private sector, or do they go to other informal providers like traditional healers? And finally, we'll take an equity lens and look at how socioeconomic status affects care seeking. Specifically, how do levels and patterns of care seeking vary between caregivers from the poorest and wealthiest households in each country? As I mentioned, we're using demographic and health survey data. These are nationally representative household surveys, and whenever a household that's selected has a mother of young children in it, mothers are asked about each of their children who are ages 5 years old or younger. They're asked if their child experienced a cough in the last 2 weeks before the interview. If they had a cough, they're asked if they experienced rapid or difficult breathing that was chest-related, and if so, that gets categorized as acute respiratory infection symptoms. Moms are asked if their kids had a fever, and if they had diarrhea in the last 2 weeks. The reason that we're focusing on these 3 illnesses is that they're proxy measures for serious treatable diseases. In the demographic and health survey data, they don't actually test for pneumonia, for example. So we rely on mothers' reports of these illnesses to capture ARI, which is a proxy for suspected pneumonia, fever, which is a proxy for potential malaria, and diarrhea, which is a very direct proxy for diarrheal disease. And these 3 diseases are leading causes of under 5 mortality in the priority countries. So mothers are asked if their child experienced any of these illnesses, and if she says yes to any of those, she's asked if they sought advice or treatment from any source. If she says yes to that, she's asked what source, where did they seek treatment? And that's the information that we're going to be looking at today on source. We're focusing here on out-of-home care seeking because that's kind of the standard that should be ideally achieved. When children have ARI symptoms, for example, parents probably should be seeking treatment or at least advice outside the home. So with that, let's look at our first research question on the burden of disease. To answer that question, we made this graph. We organized the 3 regions across the bottom of the graph. Please note that these regions are not comprehensive. They only include the 24 countries in this analysis, and these are just simple averages across countries. Across the vertical axis, we have the prevalence of each disease. Acute respiratory infection symptoms in dark blue, diarrhea and fever in teal, and fever in light blue. And the length of the bar shows the range across countries in that region. So for example, in Asia, the prevalence of fever in that region ranges from 13% all the way up to 38% in that region. That's Pakistan with a very high prevalence of fever. And the average for that region is 26%. So 26% of kids on average experienced fever in the last 2 weeks. Taking another example, moving to East and Southern Africa, here in the dark blue, we see that the range of ARI prevalence is from a minimum of 2% up to a maximum of 9%. That's in Mozambique. And the average for that region is 5%. So we see in general that there's a wide range of disease prevalence across these regions and countries. And we see that in all regions, they follow the same pattern. ARI is least common, then followed by diarrheal disease, and fever tends to be the most common across countries. So when we combine data to try to summarize the results across all of the countries, we find that these illnesses are very, very common. On average, across the 24 priority countries, 1 out of every 3 children experienced 1 or more of these treatable illnesses in the last 2 weeks. So that's a full third of children who experienced 1 of these illnesses or more. So we see that we're dealing with a very large-scale problem, that these illnesses are very common. So next, we're going to look at, among parents of sick children, what percent sought care outside the home. This breaks down the levels across, on average, across 24 countries of the percentage of caregivers who sought care outside the home for acute respiratory infection, fever, and diarrhea. So we see that that ranges between 64% for diarrhea and 70% for acute respiratory infection, or about 2/3 of caregivers who sought care outside the home for all 3 illnesses. The level is a little bit higher at 70% for ARI and a little bit lower at 64% for diarrhea. And one possible explanation is that diarrhea can be successfully managed at home if caregivers are keeping oral rehydration salts, ORS, in their homes. And we'll actually hear more about a program doing just that in the East and Southern Africa webinar. Overall, though, we see that the level of care seeking does not vary tremendously across type of illness, which might be surprising considering that, as we saw, ARI is a pretty rare illness and fever is a pretty common one. But we see that parents seem to be seeking care at similar levels regardless of the type of symptoms that their child has. Where we do see quite a lot of range in care seeking is across countries. So this is among caregivers whose child had one or more of these three illnesses. What percentage sought care outside the home? That ranges from a minimum of 40%, 39% in Ethiopia, all the way up to a maximum at the top of the graph of 87% of caregivers seeking care for their sick children in Indonesia. As we go through the rest of the presentation, we're going to focus on two example countries that have very different patterns, and we're going to compare and contrast them. Ethiopia, which is in the East and Southern Africa region, where the care-seeking level is 39%, and Bangladesh in Asia, where the care-seeking level is 84%. So now let's look at among those who sought care outside of the home, among those in those teal bars, where did they go? Did they go to public sources, private sources, or other sources of care? And this table shows how we're categorizing public, private, and other. So public sector is exactly what you would expect: hospitals, clinics, health posts, community health workers. The private sector in our categorization includes private clinics, also NGOs and FBOs, non-governmental and faith-based organizations, as well as pharmacies, shops, and markets. We categorize traditional healers, friends and family members, and any other non-informal sector providers into the other category. And we're going to maintain these three colors throughout the rest of the graphs in this presentation. Light blue is always going to mean public sector, dark blue private sector, and other sectors are always going to be shown in this orange color. This graph shows the percentage of caregivers who use public, private, or other sources of care across the three illnesses. So the first thing to note is that we see that both the public and private sectors are really important sources of sick child care. About half of caregivers go to the public sector, 51 to 53% across the illnesses, and about between 41 and 44% of caregivers go to the private sector when they're seeking care for their sick children. Only a small percentage go to traditional healers or other informal sector providers, 5 to 7%. Interestingly, we see that caregivers are not only seeking care at the same levels, but they're also using the same sources of care across the three illnesses, regardless of whether that child is experiencing ARI, diarrhea, or fever. Where we do see a lot of variation in sources is when we look at this by region. So these are just simple averages across the countries in the region that were included in our 24 countries in analysis. And this is the source that mothers reported where they went to for sick child care for any of these three diseases. We now have this small teal bar, which represents parents who said that they went to both the public and the private sector. And that's still a really small percentage. We do see a lot of difference in the patterns of public versus private. So in West and Central Africa, we see that there's a pretty even split, so about 51% going to the public sector versus this 40% going to the private sector in dark blue here. In East and Southern Africa, the vast majority are going to the public sector, right? So we see 70% and only a quarter are going to the private sector. And in Asia, we see almost the reverse, 31% going to public and 61% going to the private sector. We see even more variation when we split this out by country. So this graph shows that there's a tremendous source of variation across countries. We see that the public sector use ranges from very small, very minimal, and only 11% of caregivers go to the public sector in Pakistan, all the way down to almost all caregivers in Mozambique, 92% going to the public sector. And we also see the reverse, very small percentage of caregivers going to the private sector in some countries, all the way down to 2% in Mozambique, whereas in Pakistan, 86% are going to the private sector. Looking again at our two focus countries, these are some good examples of these kind of very contrasting patterns that we see. Bangladesh is private sector dominant, whereas Ethiopia is public sector dominant. And Bangladesh is one of the few countries that has a large percentage in this orange bar, right? In Bangladesh, we see that almost a third of caregivers are going to other providers. And in Bangladesh, this is almost entirely what's called unqualified doctors. The only other country where we really have a lot of people going to the informal sector is Mali, and there it's mostly traditional healers. When we summarize all of these data across countries, we see that out of every 100 parents who are seeking care for their sick children, 50 of them go to the public sector, 43 of them would go to the private sector, and the rest go either to both sources of care or to other informal sector providers. And I have to admit, when I first saw this result, I was really surprised. So in my own experience, prior to working for Shops Plus, I really had not thought very much about the private sector. I worked almost entirely with public sectors in these countries. And so I was really surprised to see that if countries only focus on the public sector, they're missing a really substantial part and nearly half of the sources that parents are relying on to care for their sick children. So we feel like this has really strong program implications for, and implications for also policies. So diving a little bit deeper into the data, let's look at clinical versus non-clinical sources of care. We're going to take the public sector and split that into clinical versus non-clinical sources of care, where non-clinical sources of care would be community health and other outreach workers who work outside of a clinic. In the private sector, that would be the non-clinical sector would be pharmacies, shops, and markets. So for example, this is the graph that we saw before. So for example, for ARI, we're going to take this 53% public and 42% private and split that so that we have 51% of the public, that 53 public sector into 51% who are going to public clinical sources of care and 2% who are going to public non-clinical sources of care. Again, that's mostly community health workers. We take that 42% of who are going to the private sector and split that into 23% who are going to private clinical sources of care and 19% who are going to private non-clinical sources of care. So we see overall very low use of public clinical services and a pretty even split between public clinical and non-clinical sources across all three illnesses. And again, these patterns don't really seem to vary very much by illness. Looking at this by region, so again, we have public clinical in the light blue, public non-clinical in the lighter blue, private clinical, and private non-clinical in the dark blue. And so we see that public sector care is primarily non-clinical, and that does not vary across regions. Where there is variation is in the private sector. In Asia, for example, at the bottom of the graph, the private sector is predominantly clinical, right? 41% of those of care seekers are going to private clinical sources of care. In East and Southern Africa, the private sector is more evenly split between clinical and non-clinical. And in West and Central Africa, those who are going to the private sector are predominantly going to non-clinical sources of care, such as pharmacies and drug shops and markets. When we look at the clinical and non-clinical split across countries, this slide shows the overall breakdown. So on the left in light blue, we see that among those who are going to the public sector, the large majority, 97%, are going to clinical sources. On average across countries, only 3% of those who are going to a clinical source those who are going to the public sector, are using a non-clinical source, so like a community health worker. In contrast, on the right side of the screen, in dark blue, we see that among private sector care seekers, half of them are using clinical sources and half of them are using non-clinical sources like pharmacies, shops, and markets. So when we've presented these data to our country partners and other stakeholders, we've gotten feedback that this number in the lower left-hand corner, this 3% non-clinical public, is really surprising because almost all of our country partners felt like the community health workers are a really important part of the healthcare system in their countries. So I want to note here that this does not suggest in any way that CHWs, community health workers, are unimportant. So we have to remember that these are averages across countries and that the data are drawn from nationally representative data. We know that the role of CHWs really varies across regions and communities, and we also know that CHWs often target their services to the most remote and vulnerable communities, and so they're often really critically important to those they serve. We've also heard from some of our country partners that many CHWs focus more on education and prevention messaging rather than on providing treatment, so that it's possible that CHWs are helping drive higher sources of care seeking, even though they're not cited as the source for advice or treatment. So finally, looking at our last research question on how patterns of care vary between the poorest and wealthiest households, we're going to draw this information from DHS wealth quintiles. DHS doesn't ask questions about income. Instead, they ask questions about assets, so about whether anybody in the household owns a bicycle, a telephone, whether that household has electricity, and those questions vary within each country, so they're all country specific. They then compile this asset index into a distribution of households within that country and divide it into 5 even segments of the population. We're going to compare the poorest 20% of the population, that would be the lowest quintile, with the wealthiest 20% of the population, the highest quintile, using the DHS wealth quintiles. Malia mentioned in her introduction that there is a gap between rich and poor, and that's exactly what's visualized here. We're looking at the gap in care seeking between families in the poorest households and the wealthiest households. So the longer the bar is, the greater the disparity between levels of care seeking among the poorest and among the wealthiest within each country. We see that there's quite a range. Ethiopia is at the top of this graph with 28% of caregivers in the poorest households, that's in that teal bubble, seeking care outside the home, compared to 56% of the wealthiest households. Down towards the bottom of the graph, we see that in many countries, there's a much more equitable distribution. So there's much more similar levels of care seeking between the poorest and wealthiest households in, for example, Zambia and Kenya and Ghana. And when we look at our 2 example countries, we see exactly this pattern, right? So Ethiopia not only has a very low level of care seeking overall, but also a very high level of inequity in care seeking between the poorest and the wealthiest. Whereas Bangladesh has a very high level of care seeking overall and very, very similar, almost the same level of care seeking between the poorest and the wealthiest households. So now let's look at where caregivers are going. This is the same bar graph that we showed earlier for each country with, that breaks down the caregivers going to public, private, both or other sources of care. And now we're splitting it. The top bar shows the sources of care among the caregivers in the poorest households. And the bottom bar shows sources of care for those in the wealthiest households. And this is for Ethiopia. And in Ethiopia, we know that the majority use the public sector, but that varies. In this top bar, we see that 80% of those in the poorest households are going to the public sector compared to 64% of those in the wealthiest households. Private sector use is much higher among the wealthiest families. That's 35% of those in the wealthiest households are using the private sector for sick child care compared to 18% of those in the poorest. And that's exactly what we would expect to see. We would expect to see higher use of the public sector among the poorer families and higher use of the private sector among the wealthier families who we assume have some more ability to pay for services. Interestingly, in Ethiopia, we see almost no use of the informal sector. There's just this tiny little sliver of this orange bar right here, and also very low use of anybody going to both the public and private sectors, which is very different than what we see in Bangladesh. So again, this is Bangladesh, and we've split this into the poorest households on the top bar and the wealthiest households in the bottom bar. In Bangladesh, we know that the private sector is the primary source, and there is some variation in that. We see that the private sector, 45% of families are going to the private sector among the poorest households in the top bar, compared to 73% of families going to the private sector among the wealthiest. Public sector use is much lower, but we do see higher levels of public sector use among the poorest households, 19% versus 10%. And interestingly, in Bangladesh, use of other sources of care is really substantial, right? We see over a third, 36% of families from the poorest quintile are going to traditional care sources for care. So that's in Bangladesh, that's unqualified doctors for the most part, compared to a smaller percentage going to the informal sector in the wealthiest households. So in Bangladesh, this is something that has major implications for policies and programming, especially that because it's possible that unqualified doctors, that there might be concerns about the quality of care that they're providing. So I think each country could have a story just like this to tell. And I encourage you to join us for the regional webinars where we'll hear some of those stories from the participants who know them the best. To summarize results across countries, we saw that 1 out of every 3 children experienced one of these treatable illnesses that we looked at in the past 2 weeks. So the burden of illness is very high. These illnesses are very common. On average, we saw that 68% of caregivers sought treatment outside the home. There's very little variation across illness, but it varies by country. And we saw that 50% are using the public sector and 43% are going to the private sector. We saw that sources of care really vary by region. In East and Southern Africa, the public sector is dominant. West and Central Africa has more of a public and private split. And in Asia, the private sector is dominant. We also saw that private sector use is important across socioeconomic status, right? So I think a common misconception is that the private sector is only for the wealthiest households, but we saw that a substantial portion of those in the poorest households are using it as well. And when we look at that average across countries, we see that 54%, or nearly 3 out of every 5 caregivers in the wealthiest families are relying on the private sector, along with more than a third, 37% of the poorest caregivers relying on the private sector for care for their sick children. To find out more information, you can go to shopsplusproject.org, where you can download our global brief. This is a picture of it, which summarizes these results across 24 priority countries. If you're in one of the priority countries, I strongly encourage you to tune in not only for the regional webinars, but also to download your country-specific brief. So these are going to be released along with the regional webinar for that country. So we've made 24 4-page briefs, one for each country with the country-specific findings, and also slide decks for each country so that you can download that have all of these graphs and data visualizations for each of those countries that you can then download and use in your own presentations. We also have this interactive data website that we're going to talk about for the last 5 minutes of the presentation, but right now I encourage you to submit your questions. Thanks.
We know that a higher care-seeking level is better. But when you talk about sources of care, what are the optimal results? Is there an ideal combination of public and private sector use?
Okay, great. Thanks. So that's a great question, and this definitely varies from country to country. I think the ideal combination is one in which there's products and services available to everybody in the population who wants to use them. So that's the cornerstone of what we talk about as a total market approach. In practice, that might mean, for example, strengthening the private sector if it offers particular benefits such as accessibility or convenience, which is something that we've heard from our country partners. And one of the things that can do is reduce the total burden on the public sector so that the public sector can focus on serving the most vulnerable families who might otherwise be unable to afford sick child care. But I would say that the answer definitely varies across country settings.
Great, thank you. We've received a few questions about the quality of care being provided. Do you have any comments or insights into what we can say about the quality of care and if that varies by source?
So that's a really important question. This is a secondary analysis of DHS data, and DHS is really good at giving us the what, so we know where people went for care, but not necessarily the why or the how. So there are some other resources that look at quality of care. DHS asks a couple of questions that are quality related for family planning, but not very much on sick child care. They do have SPA surveys, service provision assessment surveys, that look more into this. But I think where we're going to get a lot more information is from qualitative sources. We know, and we're going to hear some more in, I think, the West and Central Africa region, we know from some other studies that perceptions about quality of care are really important in driving stakeholders and driving care seekers to perhaps the private sector, perhaps the public sector, and in fact in seeking care at all. If they perceive that they're not going to get good quality care, they may not seek care at all for their sick children, perhaps until it's too late.
So in terms of the categories of sources of care, could you talk a little bit about how you created that? And in particular, someone's asking that there's a lot of country-specific codes and sort of how you reconcile that into the categories you presented today.
With a lot of work. I can tell that whoever asked that question knows DHS data and knows about country-specific codes. So we looked through each country and in some cases sat down with our country partners to try to figure out where ADOs in Tanzania, for example, should be categorized. So we followed DHS classification for most cases for public and private and other categories, except that because there's so much reliance on like drug shops, for example, and Shops Plus does some work with drug shops, we wanted to make sure that we classified shops, for example, and markets as a private source of care, specifically private non-clinical, and that turns out to be a really important source of sick child care.
Great, thank you. So in the beginning of the presentation, you mentioned that ARI is the least common illness across regions, while fever is the most common. Could you elaborate on why you think that's the case?
Yeah, so fever is, we think of it as a proxy for malaria, which is, we know, a very common childhood illness. But it's also a non-specific proxy, which means that when a child has a fever, they could be sick with a number of illnesses other than malaria. So if you have a child, you know that kids get sick and run fevers a lot, and it's a very common symptom of many illnesses, so that's probably why it's the most common across countries. On the other hand, ARI symptoms are a proxy for pneumonia, which is less common among children. So ARI symptoms are defined, we followed the DHS definition. It's a cough with chest-related rapid or difficult breathing. These symptoms are much more specific, making them less common, which is good because we know that pneumonia can be a deadly disease in many of these countries.
Great, thank you. So we have one question specifically about the private sector sources. Did you see differences between using an NGO or faith-based organization clinic versus a private hospital or other private clinic?
Faith-based organizations or FBOs or NGOs play a really important role in several of the countries that we looked at, and we're going to hear a little bit more about that, I think, particularly with our participant from the DR Congo. That really does vary quite a bit across countries, so I don't think we're really able to generalize, though it is definitely something that's really important within each specific country context.
Mm-hmm. Great. So we have one more DHS-specific question here. Is there an additional question that you would have found particularly useful to have in the DHS survey that's not currently included?
Ooh, good question. I'm hesitant to do this because I've also analyzed DHS data looking at adding questions, and we find that the longer the questionnaire gets, there's some cost for data quality. So I'm gonna scale back on answering that because I think we should not add anything to the DHS. It's a fantastic resource, and I think we need to preserve it and preserve the data quality. I do think that it's really important to look at the data that we get from this incredibly rich source that is the DHS in context with other sources, for example, including qualitative data that's specific to each context that can give us answers to the why questions.
Great. The next question is on disease prevalence. So household survey data is affected by seasonality issues as well as specific geographic areas and malaria, if malaria is endemic in a particular area. So was this taken into consideration when analyzing the data?
So we wanted to look predominantly we focused on sources of care, and because we didn't see that sources of care varied by illness, we don't think that it's going to vary a whole lot with seasonality. You're absolutely right that fever is going to be much more common in the malaria season. Most DHS surveys tend to be conducted in the dry season because it's easier to travel around the country at that time. Whereas malaria would be probably more common in the rainy season. So it's possible that fever could actually be even more common in the rainy season. But again, which surprised me, I have to say, because we don't see that parents are going to different sources of care when their child has fever versus when they have ARI or diarrhea, we think that these results probably would hold true regardless of seasonality.
So here's a question thinking about the implications. So we have a question from Afghanistan. What, in your opinion, are the implications of this analysis on those who are not seeking care?
That's a great question. And you know, the USAID's mandate here is to try to reduce child mortality and reduce child morbidity. And we know that if people aren't seeking care, we know that there are severe implications sometimes on child health, up to and including child mortality. So I think one of the most serious implications that we see is in the gap between rich and poor. And we don't know whether that's in care seeking outside the home. We see really large gaps in some countries like Ethiopia, for example. And we know that we tend to see higher child morbidity and mortality among those in the poorest quintile. So I think we really need to make sure that our policies and programs are focusing on extending access to those who need it most, including the poorest families, so that everybody can get the care they need.
Great, thank you. We've had a few questions about the role of supply and whether we were able to investigate that, or just your thoughts on whether supply, including access, again, quality, or distance to the nearest facility, are an influential factor for demand.
So I guess a couple of things there. The secondary data analysis, we don't really have information about supply in the DHS. There is some information in SPA surveys. But I'll talk a little bit about what I've seen on Shops Plus. We work in Afghanistan, and we work with ASMO there, the Afghan Social Marketing Organization. And ASMO is one of the primary distributors of child health and family planning products. And we know that when ASMO is not able to distribute, for example, ORS, that many, many families across the country are not able to access these really important products for their sick children. So I think it's essential to make sure that products and services are available across the country. And that's something that, one of the things I'm learning as I'm part of Shops Plus, that the private sector is in some cases uniquely positioned to be able to do.
Great. So we have another question here about community health worker utilization, and just clarifying whether the survey is done in urban as well as rural areas, because DHWs are often focused more in rural areas.
Yeah, that's a great question. We do see, so DHS surveys are nationally representative, so they're going to be, the population is going to be as large a percent rural as the population distribution is in that country. We do see some really interesting patterns by urban and rural residents, and this is a nice plug for private sector counts. You are able to look at the data for your country on private sector counts and disaggregate that data by urban and rural residents to see how those patterns change. So as I said, that number that we cited across all countries is on average across the entire population. It does tend to be somewhat higher in rural areas.
And one more clarifying question here. Someone's wondering if the research at the hospital level demarcated between primary, secondary, and tertiary level facilities.
That data is available in the DHS. We didn't disaggregate by that. We were looking just at public clinical versus non-clinical and private clinical versus non-clinical. Incorporated in that public clinical, for example, would be primary, secondary, and tertiary care facilities in the public sector. But DHS does have that information if you want to dig further.
In terms of the differences in sources of care used by the poorest and the wealthiest, do you think that that could be correlated to inequality levels at a country level as defined by the Gini index?
Ooh, interesting question. I'll bet that there is. I don't know, though. That sounds like a very interesting research question that I encourage the person who asked that question to pursue.
And could you talk a little bit about differences in clinical versus non-clinical care? For example, if there's a drug shop that has a clinician on site, how is that defined?
Yeah, so that's something that we struggled with in our analysis because all we have to go on is the source. So we don't have information about whether there was a clinician on staff. So it's possible that that we are miscategorizing in some cases non-clinical sources or clinical sources as non-clinical if, as you say, there is a clinician on staff in a drug shop. I don't think that there's a really high percentage of settings where that's the case, but it's totally possible. All the information that we have comes from source information.
Mm-hmm. And did the country-specific results include any subnational data?
Ooh, I'm so glad you asked. Man, are you like, okay, you didn't make that question up, right, Tess? Okay, so plug for the West and Central African upcoming webinar next Tuesday. In Nigeria, we were able to disaggregate the data by region, and we have some really interesting results there that about both the level of the burden of illness and the level of care seeking subnationally by region in Nigeria. And again, you can also look at urban and rural disaggregation for every country on private sector counts.
Great, thank you. So I think we just have time for one more question. Could you talk a little bit about the so what of this analysis? How do you anticipate or hope that these results might be used?
Oh, these are great questions. Thank you all so much for sending these in. Our ultimate aim for this analysis is that the country-specific findings are really used to inform policies and programs at the country level. And as we've been preparing for these regional webinars, we've been working with USAID missions from some of the countries included in this analysis, and this work has been really fantastic. We've been able to think critically with mission staff about what these findings mean within the country context, think about what questions these results might raise, and when additional research, for example, at the subnational level is warranted. Some of these results that we've been looking through have been really surprising to the country audience, and we're hoping that these catalyze new conversations that would not otherwise have taken place and cause program implementers to rethink some of their programs, perhaps, making decisions based on the data.
Great, thanks so much, Sarah.
Great, thank you.
So before we close today, I'm going to demonstrate Private Sector Counts, which, like Sarah mentioned, is an interactive website that houses all of the data you've seen today, plus more. It allows the user to explore if and where caregivers obtain sick child care. So this is the home page of Private Sector Counts, and you can access the child health data by clicking on this button at the bottom, here on the photo, or on this button at the top. So once you click, you're led straight to the data, and on the right-hand side is our main menu. You can see the 3 research questions that Sarah presented on today. So first here, we're looking at illness prevalence. What % of children get sick? So here I've disaggregated the data so that we're looking only at countries from West and Central Africa. You can choose any of our 3 regions or just specific countries within the regions or across regions. So this graph shows the illness prevalence for each of the 3 diseases, ARI, diarrhea, and fever, as well as the combined illness prevalence for children who are sick with at least one of these illnesses. So also on the right-hand side, there's a demographics menu, and you can further disaggregate the data by socioeconomic status, looking at just the poorest and wealthiest quintiles, or at all 5 of the DHS wealth quintiles. You can also look at rural versus urban residents, something that we did not have time to discuss today, or maternal education. So I'll go ahead and select the poorest and richest quintiles, and I get this graph, which shows me the differences in illness prevalence for the countries in West and Central Africa between the poorest and richest families. So next I can move on to our next research question, looking at the level of care seeking outside the home. And here I have selected the Asia region. And if I hover over any of the bars in the graph, a little box comes up telling me the exact percentage of the data point I'm examining. So you can see that in Afghanistan, 69% of families seek care for their children with ARI. I can also disaggregate this graph by rural and urban residents, and I get this bar graph where the yellow shows rural care seeking and the dark blue shows urban care seeking. And I can also look at this instead of as a bar graph as a bubble chart by selecting this button on the bottom right. So this is another way to easily see differences in the demographic characteristic that you've selected. The longer the line between the bubbles, the bigger the difference is. So lastly, I can look at sources of sick child care. And here I'm looking at all 24 of the countries analyzed. And for any graph, if you would like to download the data, you can click on this icon at the bottom right with the red box around it, and this menu pops up, and you can select various formats for downloading the data. So you can download the entire visualization as an image or a PDF, or you can download the data directly into an Excel file. Lastly, you can always use the About This Tool button on the top navigation bar if you have any questions and want to learn more about how the website works. And if you have further questions, you can always email us at info@shopsplusproject.org. So this website is live now. We encourage you to go check out privatesectorcounts.org to play with the data and look at the statistics for your country. And I'll turn things back over to Sarah to wrap up today's webinar.
Great. Thank you so much, Tess. I want to make sure to thank Tess, who, along with Lauren Rosapet, co-authored this study with me. Thank you also to our colleagues at Shops Plus and Apt Associates, and many thanks to our colleagues at USAID who helped guide this analysis. This was truly a group effort. I want to put in one more plug for our regional webinars where you're going to hear from the real experts who can definitely give much more detailed answers to some of these questions. You'll hear from folks who are implementing programs on the ground in Nigeria, in the DRC, Uganda, Zambia, India, Nepal, and Myanmar. As I mentioned, preparing for this webinar series with these panelists and hearing their stories has been fascinating and so much fun. I'm looking forward to these regional webinars, and I hope you'll join us. Thanks so much.